Morning, everyone, and welcome to the Stopping Sepsis in Virginia Hospitals and Nursing Homes Hospital Webinar number 2. My name is Betsy Archer, and I will be your host for today's webinar. A couple housekeeping items before we move into the content. The slides were sent this morning by Ms. Wanda Clevenger. This webinar is being recorded. We do ask that you please use the telephone option to call in and join the webinar. You'll be prompted to provide your audio PIN. This will allow you to verbally ask a question of today's presenters during the Q&A session at the end of the webinar. All participants are muted at this time. I do encourage you to ask questions. You have 2 options to do so. If you did dial in using your telephone option, you may raise your hand and you access that feature by locating the palm in the blue circle with the arrow. It is highlighted on your screen by a red box in your GoToWebinar platform. And that's, again, only if you called in using your telephone. You also have the option of asking a question using the questions portal of the GoToWebinar platform. And you would simply type in your question. We will hold all questions to the end to make sure that we can cover all content. And with that, I will turn things over to Wanda Clevenger. Wanda?
Great. Thank you, Betsy. And again, welcome to today's Stopping Sepsis Hospital Webinar number 2. Today we're going to be reviewing the Sepsis Practice Collaborative Model Tier number 1. And that is really the foundational work for your sepsis program. We will also discuss the sepsis gap analysis and some tools for developing a program action plan. We will touch base on the box program, which is used to receive and also upload data to us regarding your sepsis performance measures. Today, I'm joined by Kathleen Volman, but I'd like to take a moment and just introduce our sepsis support team. From Health Quality Innovators, Deb Smith and Candy Hamner are working with the nursing homes in this project, as well as collaborating with the hospitals and with the VHHA team regarding the sepsis program. Betsy Cole Archer is with us today and facilitating our webinar. And then, as I mentioned, Kathleen Volman is our sepsis content expert. And so I am going to allow Kathleen the stage, and she is going to take over the webinar for a bit and begin Tier 1 of her organizational consensus on severe sepsis management. Kathleen?
Thank you, Wanda. I'm really excited to be with you this morning and really focus on some of the fundamental or foundational work that is necessary to be successful in your sepsis program. And so it really takes teamwork. And if we don't start at the foundation, the challenge is we're going to be sort of plugging a dam finger at a time instead of addressing the work that needs to happen. And so this is the model that I introduced to you initially. We are going to be focusing on the base of the pyramid, not the infection prevention component, but organizational consensus that severe sepsis must be managed early and aggressive. And towards the end, we'll talk a little bit about screening, but screening is entity in and of itself trying to find the septic patient. So I would suspect our next webinar is going to be focusing on that. So when we look at organizational consensus and support, there are some milestones that you need to reach in this area. And one is defining your sepsis program goals. And do they actually align with the organizational goals? Now, I'll be honest, let me go back for a second. I'll be honest, one of the things most hospitals do not have in their strategic goals, sepsis. And if your hospital does, that's awesome. But if it doesn't, most hospitals have reduced mortality. And by lowering mortality, one of the major strategies to do it is get a handle on your sepsis population, because I'm going to share with you some data that shows a good percentage, or at least close to 50% of most hospitals' mortality is related to sepsis. So through this webinar, we're going to have some polling questions so that we can garner some information about where everybody is starting. I know you completed your gap analysis, but I would like the opportunity for us to learn right as we go. And so the first question I'd like to ask you, how aligned is your sepsis program with your organizational's quality improvement initiative or patient-centered goals, their strategic plan? So if you could vote, and then the results are going to show up. So I could play a little Jeopardy music, but I'm going to save you from having to listen to me potentially carry a tune. But the key of understanding and why connecting the organizational quality improvement goals to sepsis is to ensure that it is on the C-suite's radar. Because it also, in order to be successful, requires organizational commitment and resources, resources around data abstraction. Okay, so here we go. Poll results show that about 45% are aligned, so that's great. The programs recognized, but data needs are not necessarily prioritized, and that's around 30%. So that and not connected at all. So we're looking at a little over 50%. So this is an opportunity as a group to really talk about how do you make that happen, and we're going to be discussing that as we go. Oops, sorry. So do you have a sepsis program team committee charter? And again, this reaches the concept of how do you make this official within your organization so that it is not just sitting in your quality department as a quote-unquote core measure. Because if that's what you're experiencing, it's going to be very hard to be successful in making a dent in the sepsis initiative, because it is a full court press program. It can't just be the quality individuals addressing this. So, oh great, so 90% have a team charter. So the question is, on that charter, did the executive sign off on the importance of why I need those resources? And according to the previous question, it looks like over 50% of you may have got the nod, but not necessarily the resources that partnered with it. So that then becomes a challenge for you, especially if you're in the team lead as a part of this journey. So what I wanted to share with you, in case you didn't have a charter or a policy related to this, is an example looking at what are your outcomes. Case for change is really the business problem and the ROI, return on investment. And this is where we can help the C-suite understand that it is financially viable for the system to put some resources up front on this program. And I'm going to share some of those financials as to why. And then, as you're probably familiar with charters, they ask, what kind of milestones are you looking for? How are you going to evaluate it? Who are the team members, and then who are your executive liaison, and we're going to talk about that, and then members of the team themselves. So please feel free to use as an example. So as you're setting up this program, and by the way, 50% of you may need to reboot it in order to get those financial resources, you got to build the why. So this is a study showing economical impact directly related to protocol implementation. This was a study done at Barnes-Jewish. The original study looked at impact of use of a protocol versus routine care and the impact that that had on mortality, and then they took that research study and then applied the economics to it. So they did an analysis of the result of their prospective study. They had 120 adults who sequentially presented to the emergency room in septic shock. They had at least the 2 SIRS criteria, the known or suspected infection, and the shock they defined as requiring fluid resuscitation and vasoactive administration. So what they identified is, one, needless to say, the ones that got the protocol had a significant improvement in their mortality rate. So if that mortality rate component is aligned with strategic goals, that's one strategy you can use. But they actually did direct cost savings, and what they found is about $6,000 per patient, which translated to over $500,000 between the 2 groups. So we're talking 120 patients and $500,000 saved. So from a financial perspective, and by the way, your own organization can do this with your own patients. So one of the strategies maybe is to sit down with somebody in the CFO's office and be able to get some data on this. The other component is that mortality piece. If your hospital has that up on the strategic plan hit list, this is one hospital's organizational data from 2014 on their acute care discharges. About 11% of the patients had a sepsis diagnosis, but 50% of the patients of the acute care deaths in that hospital had a sepsis diagnosis. So in essence, a good percentage of the mortality in this particular facility, it was related to sepsis. So if I'm targeting sepsis, I can reduce and lower mortality rate. Now I know that's a single institution. Here it is in a larger study. This was done by the group in Northern Kaiser Permanente. So they took their data and they also took the national inpatient sample database. And they did some comparisons, and literally what they identified is 1 out of every 2 to 3 deaths is related to sepsis, and most of it is present on admission. So in the adult world, about 80% is present on admission, and it's about a 50-50 in the pediatric world. Now, what I found interesting about this particular study is the fact that in the Kaiser Permanente data, the patients who presented in septic shock or presented blatant that received the early goal-directed therapy, they made up 33% of that mortality. The patients that presented with a normal blood pressure and a lactate between 2 and 4 made up 56% of the deaths. So in essence, what it's saying is we're having trouble identifying, we'll talk more about this in screening, those patients that don't look as sick. But again, the message here is the impact on mortality. Now, this is where you start to get into the hospital repayment system and that readmission penalty component, and this was just published in JAMA in 2017. Proportion and cost of unplanned 30-day readmission after sepsis, and they used the 2013 nationwide readmission database. And in essence, you can see that sepsis and in the sensitivity analysis that both of them are on the top of the list associated with 30-day readmission. So needless to say, if your organization has left money on the table related to the readmission penalties, this may be another financial strategy to build your ROI case in order to get data resources, sepsis coordinators, and time for education and teams. Again, another piece is literally, and this is out of that same study, literally showing that the majority of the deaths, or at least half of the mortality rate in inpatient hospitals, is related to sepsis. And here you can also see, depending on the age range in your facilities, after 65 years of age, the increase of sepsis and septicemia exponentially goes up. which most of us have probably completely been aware of it. Common cause of hospitalization for adults over 85 years old. As you can see, congestive heart failure sits up there, but when you put pneumonia, urinary tract, and septicemia, which usually all fall under the sepsis bucket, it puts it at a significantly higher rate as to who's getting admitted to our hospitals as a part of it. And then you can also make the point of discharge disposition after sepsis. In comparison to other diagnoses, a greater percentage of patients end up going to either a short-term or a long-term care institution. And then there is potential bounce back. So some of the major reasons for bounce back from long-term care are sepsis, either CAUTI related or pneumonia related. So again, all of this can be used to help build that case, to get it aligned and get the resources you need. Identifying an executive sponsor is critical. You saw in the project charter that may have been called a executive liaison. You can call it an executive sponsor, and really looking at what this sponsor does. And we're going to talk about that role, but I have a couple of questions to ask you first. So how engaged is your sepsis executive leader? Not engaged, partially engaged, rises to some of the challenge, rises to most of the challenge, and fully engaged. Because how engaged they are and how you're able to access them to bust through some of the turf wars that occur during this sepsis journey is really critical. Because in this quality improvement, I like to tend to call sepsis a big hairy beast. We've gotten used to fixing stuff in the ER, fixing stuff in the ICU, fixing stuff on the floor. This literally requires us to change the way people practice in all of these areas. And so everybody has to play in the sandbox together and talk to each other. So that makes a role. So what do we have here? Partially engaged, 14%, rises to some of the challenge, 24%. By the way, I'm excited to see 38% fully engaged. Rises to most challenges, 24%. So we're looking over 55% of your executive sponsors are engaged actively in this process, which is great. That's very great to hear. All righty. Oops. Let me go back. All right. So this is a question, and please select all that apply. Does your executive leader request meeting minutes and ask follow-up questions on them? Do they attend meetings? Do they hold regular check-in meetings with the sepsis chair? So even if they don't attend meetings, do they connect with the lead? Are they connected to the C-suite on the business case and resource requirement? And are they addressing noncompliance with evidence-based best practice? So do they help talk, if it's, do they discuss with the chief medical officer or the chief nursing officer how to address some of these individuals that may not want to participate in the sepsis journey? And the reason why we asked, you can probably figure out it's a teaching mode too. These are all the things they should be doing. And so, so it's a critical component. And by the way, if they don't regularly attend meetings, that's okay. But if they're looking at the minutes, they're available to the chair to connect when the chair is having challenges. Okay, so 56% attend meetings. That's great. Hold regular check-ins with the chair, address noncompliance. Oh, this is wonderful. So do we have full compliance on it? No, but above 50%. So the ones that don't, it's important to work to try and engage them through, again, building the business case, officially creating a charter, and understanding what that charter means to a commitment at the organizational level. And so, as you can see, whoops. So literally they should be looking at the project plan, as I said, reviewing the team minutes, anticipating barriers, giving voice to organizational sepsis, the organizational sepsis work, and maintain alignment with the goals of the organization. So I'm going to give you an example of how this comes into play. An organization was having challenges in the emergency room with the emergency room physicians getting a patient that literally was in septic shock, but a lactate greater than 4, so not necessarily hypotensive, but defined by greater than a lactate of 4, in the presence of severe sepsis, and so the known or suspected infection in the SIRS criteria. And then they would resuscitate the patient, and the lactate went down from 4 to 2, and so they decided that the patient should go to the general ward. And then what would end up happening is a couple hours later, the patient would crump, wind up in the ICU, and several of those patients passed away, and some of them were young. So the sepsis coordinator, besides coaching through that whole process, the sepsis coordinator ended up going to their executive sponsor, laying out these cases, laying out the issue. And this is after multiple plan, do, check, act cycles. But it finally went to the Med Exec Committee, and literally the Med Exec Committee made a commitment that if you present to the emergency room with a lactate greater than 4 in the presence of known or suspected infection and 2 SIRS criteria, you had a code sepsis and you bought yourself an ICU bed. So that is one way or one strategy to see how an executive can then move things in the organization to make changes happen. So when we look at the next step of the organizational checklist is collecting baseline data, essential steps, as well as understanding your current process. And so I have a couple of questions to ask you first, and then we'll talk about data. So one of the first questions is, do you believe your hospital's own sepsis data? Because the coding is being done directly by the DRG related sepsis. And so the question would be, how many of your organizations still have documentation of pneumonia with hypotension, CAUTI with hypotension, where severe sepsis or septic shock may not be actually named? Okay, so we have 86% believing their hospital data and 14% not. Okay, that's great to know. All right, let's move to the next one. Is the data you are given usable for your sepsis performance improvement work? So what do I mean by that? Is that it is presented, formatted, the right questions are there so that you can improve recognition and bundle compliance and ultimately mortality. And by the way, thanks everybody for engaging, because it really helps drive our learning, I believe, when we have specific data around what you're experiencing. All right, so most of you, very similar to believing your data, also believe that your data is in a usable form for improvement, which is awesome. So that's a huge step in the right direction. So, oops. I am aware you believe your data. So first off, and actually I should ask this question. If you have been working on this program for less than a year and your data, your combined severe sepsis and septic shock mortality is below 18%, I would ask you to question your data. The reason is there are organizations that have been working on this for 6, 7, 8, 9 years, and they are now reaching 12% combined severe sepsis and septic shock data in terms of mortality. So, and if your compliance, your all or none compliance is around 30%, which according to the Surviving Sepsis Campaign 30,000 database, that's the highest, you know, somewhere between 30 and 38% all or none. That is associated with an ED mortality rate of 26%, a floor mortality rate of about 38, and a ICU mortality around similar to the floor. So what I'm saying is, if your compliance is low on your bundle and you have a low mortality rate, the data you're collecting may not be getting all the patients. So one of the strategies to do just a bench check for yourself in this initiative is to follow the IHI's methodology of 20 patients per ICU. So if you do 20 charts around a similar care practice, you get within about 3% of the routine way people provide the care. So if you have multiple ICUs, you may want to do multiple ICUs, or you may just want to do one ICU as a test to see if it's accurate to what your coders and abstractors are getting. So what I would recommend is an ICU that takes emergency room patients, so that you make sure that over 50% of the charts you're looking at, the patients have come from the emergency room. Some query strategies here are the ICD-10 codes. Also then ask your medical records people for patients in your ICU that are on 1 or 2 antibiotics and vasopressors. And then what you do is you take the screening tool and you see if the patient meets the criteria for severe sepsis and septic shock, either one, or both. And if that chart rules in, analyze that chart with whatever tool you're using to extract data, you know, so that you know what your time zero is, you know when they meet that criteria and the elements, and then their mortality rate, and see if that matches. So this really doesn't take that long to do, and see if it matches your abstracting data. And if it does, you're good to go. If it doesn't, then you got to take a look at your abstraction process and some additional strategies to get accuracy in your data, because most of you know data going in and data going out, if we're going to use it to drive improvement, we have to make sure that it's accurate. So the other component is you can do this prospectively as well. You can do 20 patients prospectively to where you are following them. And what we do know is your ability to change human behavior goes down exponentially the older the data is. So if you're doing retrospective data and that's what's coming to your meeting every month, is month-old data or 2-month-old data, your ability to address and change the behaviors around compliance of the bundle elements will not be successful. Excuse me. And so when you look at this chart, the best thing to do is either prospective or concurrent as much as possible, so that you can, within a 24-hour period, get back and do coaching and discussing with regards to elements that were missed as a part of the journey, so that you can change behavior. Some places use an example of this. I've seen another, it's actually posted on the HURT website, which is very similar to this. And it's that concept of wherever the time zero starts, this document gets initiated and the time and components of the various aspects are included in this, and they are used as a handoff tool, but they can also be used as real-time data collection. So if you have a patient log in your emergency room and in your ICU, whoever are following these patients have the capability of then looking at this document and doing that real-time data collection to be able to make changes. And if you initiate any form of a code sepsis, hopefully that code sepsis is coming to the coordinators so that they are able to then follow up on those patients. So those are some strategies. The next thing is develop a sepsis team or committee. So do you have all the right people? And if you're relatively new at this, it needs to be scheduled at the meeting at least once a month, but you may want to capture the initiative and do it twice a month in the beginning. And then the other part of it is identifying both your nursing physician champions in the ED, ICU, hospitalists, and they have to attend the meetings. And also we'll talk a little bit more about this concept of a coordinator position to oversee the program. So before we dive into that, I want to ask a few of these questions. If you have a sepsis coordinator, what percentage of the job is focused on the sepsis initiative? Because what I'm seeing across the country is the person who's the sepsis coordinator may also have heart failure, they may also have COPD, or they may have CAUTI or CLAPSI or other initiatives, or another job like a clinical nurse specialist of the intensive care unit, and yes, then they run the sepsis program. So therefore it makes it extremely difficult for that individual to dedicate the kind of time based on the size of your facility to really addressing this issue. And one of the things that we have identified in the model, okay, so there's 15% that have it at 100%, and I will tell you that is critical. Especially if you are a larger size facility. It is acceptable to do a half-time FTE if your facility is probably under 200 beds. So I'm not exactly sure where that group falls in, but if it's less than 25 or 25%, it is insufficient time to make a dent in this initiative, because as I shared with you, it is a big hairy beast. And in this model implementation that we've done across the country, we have identified one of the vital behaviors is to have a sepsis coordinator where at least 50% of their job based on the size of the facility or 100% of their job is focused or dedicated to the sepsis initiative. That is what will allow that real-time feedback, data collection, and connection. And I got to tell you something, the amount of money you're going to save in reducing length of stay in this patient population and reducing mortality, I can guarantee you will make more up than the salary of this individual. So when was, another question we have to ask, when was your sepsis team or committee formed? So again, it's the concept, do you have a new committee, or is your committee older? What type of education did the whole committee receive? Did we just assume that everybody knew the science around sepsis, or did we start everybody off on the same foot? And so some of you who may have long-standing committees, you may have to do a reboot, to make sure everybody's on the same page as the science changes in that. So let's see what we have. So we have 24% of the group more than 37 months. It looks like the majority of the group is somewhere between 1 and 2 years in their formation of their committee. So I will tell you the hospitals that have been working on this still have an active sepsis committee, and some of them started in 2005. So this is something that's not really ever going to go away. Sorry for those souls out there that hope it's, you know, it's one you've got to keep your eye on. So who needs to be on that team? So please think about the composition of your team. You must have a nurse and physician champion from the emergency room and the ICU, and you need at least one physician at all these meetings so they can't blow it off. As I said, it needs to be linked to the operational and organizational structure. Meet 1 or 2 times a month. If you're in your infancy, you may want to do the 2 times. If you're more established, once a month may work. Make sure, don't just assume that everybody knows the latest evidence on sepsis because they wanted to be a champion. They may or may not, and so therefore it is critical to educate to make sure, because this team or committee is literally serving as the ambassadors to this initiative. And so if the ambassadors to this initiative don't agree on various points, you're going to have a significant amount of process variation that you're going to have to overcome. And there's already a lot of process variation around this. We also believe that having a bedside nurse from the ED, the ICU, and the med-surg area is critical, because they provide that reality check in this journey. And then, as I shared with you, another strategy that organizations have found successful, and the nurses on the call may be familiar with this concept of unit-based champions. We've run a model like that for skin and for other initiatives. So consider developing a nurse champion on each unit, and some have it per shift. So it helps with auditing on screening. It also helps that they get educated and extra knowledge so that they serve as that sepsis coordinator's frontline interface as a part of that journey. So I wanted to ask the group, do you feel you have the right people on your team? Now that also means, I mean, you may have lab on there as well, pharmacy, respiratory therapy, some of these, I would suspect having your abstractors on there is absolutely critical, and I would also consider IT on there as well, because almost anything we do is going to need to be changed within the electronic medical record to help drive compliance. Okay, so some opportunities for people to be able to improve by getting additional members, but it looks like about 80% of the group feel that they have the right members on the team. That's awesome. Okay, do you have a frontline nurse sepsis champion on every unit and for each shift? Now, it's okay if you put every unit, if you have it for every unit, you may not have it for every shift. Please mark yes if you do have, because what we're looking for is, do you have some type of frontline nurse sepsis champion program in place? And it also helps you as a clinician in Virginia to know what your peers are doing and where people are at. And I don't know, I haven't talked with Betsy or Wanda about this, but I think it would be really great if these polls are saved so that we know the percentage, so that it often could be used to help build processes within your facility. So this is an opportunity. 80% don't have one, 20% do. And actually, by the way, for the 20% that do, feel free to put a comment or at the end when we open up for questions to talk about the impact that having that champion system has on your program, and be able to share it with your colleagues as a part of this journey. Okay, and so the last piece of making sure that you have completed all the components of Tier 1 is define an action plan and time timeline for program development and implementation. And depending on where you're at in this process, your action plan may show up in different tiers or phases based on where you're at, and we'll talk about that. From the choices provided, what do you consider your main obstacle to managing sepsis at your facility? Real-time access to abstracted data, computerized order sets and alerts, lack of a dedicated sepsis resource, institutional commitment to address systemic problems, routine screening for sepsis on all floors. This is also going to help us design the next webinar or subsequent so that we can target. So we're using the gap analysis to create some of these questions to drill down some additional data in order to create programs that will value add as a part of this journey.
And Kathleen, this is Betsy. Just so you know, this is a check all that apply, so you'll have folks voting for more than one.
So this, which is great. And Betsy, can I ask a question? Are we able to save this data on the polls?
Yes, so we are recording, so we'll be able to see how folks voted, and then Wanda and I can go ahead and digest that into some saved slides for that.
Awesome. So real-time access to abstracted data, about 40%, so that's a big one. Computerized order sets and alerts, that's a big one. Lack of a dedicated sepsis resource, that puts out right there, and that's where building that business case is a critical component. So one of the things I would recommend whoever is running the program or chair of the committee or own it from the quality department is really connect with your financial people to build the business case. 22% on addressing systemic problems, routine screening 33%, and we're going to dive into that in the next series of clinical webinar. So when we look at an action plan, what we talked about right here is, and it is bolded for those components. And by the way, it's almost like a Gantt chart. It's like, what are the elements that we need to have happen? Who's owning it? What is the due date, and where are we at in the status? So when you're running a program this big, you literally should have a chart like this as to where are we at with various process. And I will share with you in terms of the screening and things like that, you may actually put points underneath as well and get more specific, because when everybody is on the same page in the direction that you're going, we get further as a part of our journey. So I'm going to hand it to Wanda to talk about how to use the gap analysis.
Great. Thank you so much, Kathleen. That was very helpful information and will certainly guide our project as we go forward. So the gap analysis that was sent out to all facilities reflects the stages in the sepsis practice collaborative model. So it's important, as Kathleen mentioned, this is not a one-time project, but this is really a system for delivering care within your organization. And I think it would be very helpful for everyone. I know we asked people to have a sign-off on their gap analysis, but more than a sign-off, I think it's important to use that gap analysis as part of this work and to engage your executive leader for support in particular areas where you do have gaps in the program that you're working to establish. So when I come out for the hospital site visits, we will be referring to that gap analysis and your results and helping to strategize next steps. Now, going on to just some housekeeping items regarding the project. Everyone should have received an invitation to Box, which is the secure data exchange that we're using for the Stopping Sepsis program. Again, it's a secure file you should have received an invitation, and the invitation expires in 7 days. So it's important to act upon it, and once you establish your folder, you're set. You don't have to reopen or reinitiate your account. So we are having support from HQI, and they are reviewing all of our participating hospitals folders to make sure somebody has activated an account. If they have not, you will be getting subsequent emails. So please act on that as soon as you can. And in case you have any questions, probably the best person to contact would be me, and then I can facilitate engaging HQI as needed. Now, within that box folder, there will be placed reports that are pushed out from HQI, and those are the sepsis outcome measure reports, but also there is a template in each hospital's folder for self-reported sepsis process measure data. And your file will look something like this. We have added one element to the data collection process following our first webinar with Kathleen, and that was looking at your overall compliance with sepsis, with the sepsis bundle. And so you'll see that under the general data. But it's pretty straightforward. We've covered these items, but again, if you have questions, please don't hesitate to contact me. There are also tracking and trending graphs underneath your data entry rows, so be sure to utilize those for your team meetings. I am in the process of scheduling hospital site visits. I want to say I probably have about half of the hospitals participating already scheduled. I'd like to complete all of the visits by July of 2017. And a requirement before I will schedule your visit is that you need to submit your gap analysis. So you can see we have 8 hospitals that have not yet submitted, and I'll be reaching out to those hospitals individually. But it is very helpful information, and I see the gap analysis as facilitating your getting a better understanding of what's required for your program, and then also helping to establish priorities. Just some upcoming webinars. We have the cross-setting webinar that will be for both hospitals and nursing homes. That's scheduled for April 25th, and you'll be getting an invitation soon. And before that April 25th date, you will also be notified that the next hospital outcome measure report will be placed in your box folder. So keep a heads up for that. And then in May, Kathleen will be joining us again for looking at tier 2 of her program regarding a coordinated sepsis management, and it will be on early screening tools and triggers. And we'll also be looking at the poll data to see if there's other components that we need to review or incorporate into that webinar. And then the next nursing home session is May 23rd. And that I don't have details, but they will be following along with sepsis prevention. We have about 12 minutes left, and we didn't think we would have time for the screening tools, although I put a few slides in here just in case. I'd like to go to questions.
Yeah,
so I'm going to go forward, and we'll be covering these slides later. But we're going to open up the lines for questions.
And actually what I'd like to do is those that answered the question that 100% of the coordinator's time is dedicated to sepsis. I would, if one of those would speak up and share how they were able to get that organizational commitment to help the others that didn't or that haven't.
Okay, at this time I will unmute all lines. Please make sure if you are not speaking that your individual line is on mute. Okay. That. Okay, ladies, I think the sound quality is not going to be good if we do that. So I'm going to
Okay.
actually ask folks to go ahead and use the raise your hand icon in order to signal that they want to speak. And it looks like, Renata, it looks like you had your hand raised. I'm going to try to go and
even if
unmute
it's
your
not
line.
even if it's not related to that question, we'll take it.
Oh. Oops. Okay, she hit it by mistake. Okay, so any volunteers for a question to get the discussion started?
On the coordinator, the other is some shared that they had sepsis liaisons on the unit. If they would like to share how that is going as a part of this journey. Because guys, it's not just learning from me, it's learning from each other, because we're all out in the field trying to figure things out. So the more you can share with your colleagues, the better this whole this whole program works. Don't be shy. Oh, come on, somebody. We had great participation on the polling questions. Well, if for some reason, don't know why, but I would ask that you guys, those two questions that I asked you, whoever has 100% of their time focused as a coordinator and who has a sepsis liaison, if you're not wanting to share it on the phone, would you be anonymously willing to share that information in an email or, you know, some way get it to us so that the other hospitals within their own environment, because it really helps to argue the point that, hey, other hospitals in Virginia are doing this. We should be able to do it too.
Okay, ladies, we have a comment. We currently screen for sepsis within 2 hours of start of shift. Are others screening with every set of vital signs? Every with capital I.
I will share with you the minimum of what we have identified that works is as part of your shift assessment. So that would be within the first 2 hours. I would suspect that that would be required as part of your shift assessment. And for some patients, and so this is where the individuality gets in. I wouldn't recommend it for every patient that has that every time you do a vital sign. But for those patients who are already sepsis and may progress towards severe sepsis or septic shock in order to catch them, but there's a way to do that. The primary screening should be done as part of the shift assessment, but depending on the computer system that you work with, there could be background screening taking place in the middle of the shift that would then send a best practice alert or a prompt that would then prompt the registered nurse to rescreen as a strategy. And I'm going to talk more about that in the next webinar. We're going to be absolutely detailing some of those strategies along the way. So that would be something I would think about, is using the computer as an independent redundancy and the nurse as the primary in the shift assessment. And we also incorporate any rapid response call gets screened automatically for severe sepsis. So the question I would ask for that individual that commented with the word extra or the word every, is that something that is occurring in your organization, and do you have data that shows it benefits the patient? In other words, have you gotten saves by it?
Oh, Kathleen, this is Wanda. They added another comment saying our hospital screens in ED triage on admission to floor and on each shift. Ongoing issue with getting nurses to recognize organ dysfunction. We do screen code blue and RRT patients. Great.
It is one of the things, and I'll talk about this at the next webinar, is and I apologize for this language, but it is the kiss of death on that screen if you connect it to the core measure, instead of connecting it to the registered nurse's advocacy role of this is what they own to prevent harm. So in understanding, and so part of the screening process is also auditing, and auditing for accuracy, not just auditing that there's a bunch of check marks that have been done, but literally auditing for accuracy and doing that teaching. By the way, that's where a sepsis unit-based champion comes in, because they can help with that auditing, and they can also help nurses recognize that organ dysfunction. And the major organ dysfunctions that happen in the med-surg area literally are respiratory and blood pressure. And in the next webinar, I am literally going to talk about that unexplained tachypnea and unexplained hypotension is a medical emergency, and talk about the physiology of why, and using that as a strategy to teach nurses in the med-surg area in a different way, because sometimes there's only reliance on the SAT monitor, and the SAT monitor has actually almost become a detriment to full respiratory, effective respiratory evaluation of the patient. So thanks, and literally what you mentioned is exactly what is recommended for screening in triage, and also again in the emergency room, depending on your length of stay, in the ED, every shift, and also with rapid response. And then this concept of having the computer do background screening and then have the nurse screen if a best practice alert or some kind of Muse warning shows up. But we'll get more into that.
So Kathleen, before or while we wait for other questions to come in, I just wanted to let the audience members know that there will be a survey and requesting their feedback for how we did on our webinar today. We invite you to go ahead and complete that survey as soon as you log out of the webinar. And I believe there's an open comments field. If perhaps you are a little shy about providing or asking one of your questions, if you want to submit a question in that survey, please feel free to do so.
Because I'll take all of those questions and respond to them and send them out to the whole group. Because this is really about that kind of interface and interchange between us. And so that evaluation is critical to us to make sure that we're either hitting the mark or we need to make adjustments. Thanks for that, Betsy.
You're very welcome. So I don't see any other questions coming in at this time. Kathleen, are you comfortable with concluding the webinar?
Yeah, I think we've teed it up. We've set the foundation of what needs to happen, and the group has an idea of where their own organization is, and what are some steps to take them to get better compliance and better engagement and better resources in order to be successful at this initiative. And then we teed up the importance of finding the patient, and that will be the May webinar, screening tools and triggers and strategies for embedding screening into the nurse's work, and how to follow up on that screening as well.
Great. Well, with that, ladies and gentlemen, we thank you for your time today, and we will conclude the broadcast. Thanks so much.
Great.
Thanks.
Thank you.
Have a great month.